does accurate mean? How do you determine your patient's nutritional requirements? I'm not only talking about energy, but we are very bad at actually really determining how much glucose, how much fat, how much proteins. Early, yes, early, but you sure saw that early will determine lots of things, but you will also have to adapt afterwards. And I will try and show you that there is some rationale and not only confusion. What we know early is how our patients look. Of course, when you see a young guy, 31-year-old male, whose CT scanner shows that there is a lot of muscle and little fat, and you look at the diameter, which is not very different, but where there is much more fat and very little lean body mass, this 85-year-old female having sustained the same trauma won't do the same and won't have the same requirements. We also know, and this paper is really worth reading, because it summarizes many of our problems, and it was not a nutritional study. It was a study done at aiming at investigating muscle wasting in critical illness. It shows that if you take a very simple examination, very cheap one, and take ultrasounds and cross-sectional area of the leg, after 10 days, most of the patients have lost more than 15% of their lean body mass. A young trauma patient is losing somewhere between 500 and 1,000 grams of muscle every day. And nutrition can't do it on its own, but can help prevent trouble. And then we are into our own difficulties. This was one of my doctorants who made this paper, has been very much cited. I'm proud of that, but it showed problems. It was actually a terrible paper. It showed that we were not able to feed the majority of our patients, and the worse we were at feeding, the worse the complications. So, yes, it makes a difference. At that time, in this paper, the targets were much higher in our surgical ICU at that time than now in the mixed ICU, because at that time we measured that we added 10% on top of that and targeted that. So we have changed the way we proceed. And they were surgical patients. But all over the world, we have the same problem. We were bad and were the first to publish, but worldwide, delivering feeds by the enteral route is difficult. And you probably have all seen this paper by Darren Halen's group, where they showed that worldwide, and these are thousands of patients, if you look at the daily calories received, well, the majority are much down the road, but there is a relationship between the calories received and the outcome. This scale shows the mortality. The group has plotted the patients by body mass index, and they show that by any group, except possibly in those who are normal, the less you feed, the more you die. But on this curve, actually, they were not able, and they show that in the next group, to show that if you go up here again, you will have the inverse effect. So there is sort of an optimal place to be, and not feeding is causing death. And the problem is that, yes, due to the fact that we know we should feed the enteral route, and that this is difficult, we have forgotten that when we use parenteral nutrition because we can't make nutrition the enteral route because it's difficult, we have a risk of overfeeding. And there is one thing which is nearly never appreciated, it's the evolutive nature of requirements. When you measure by indirect calorimetry and energy expenditure, this will depend on the muscle mass. I showed you that after 10 days, 15% of it is gone, which means that the requirements have changed. If there are complications such as sepsis or whatever, if the patient is moving, you have no way to predict if you can't measure. And most of you are not lucky to have computerized systems showing what we pump into our patients with drugs, with glucose and so on. So this adds to the lack of precision of the prescription and the delivery. Look at this. This is an American study on patients who mostly were in the ICU, and they were just investigating the frequency of bloodstream infections and try to relate them to caloric intake. They had two groups based on having bloodstream infections or no bloodstream infections. Sincerely, the caloric delivery in these patients, two groups, is not very different. But what was shocking me was that the so-called low-calorie had got 31 kilocalories per day as a mean in parental nutrition, which is huge. And of course, those who got more infections. And if you break it up, this is the interesting part of the study, is that those patients who got more than 40 kilocalories per kilo body weight per day, more than half in white had bloodstream infections. Overfeeding is a killer, is a cause of infections. Underfeeding is a cause of death and of infections. But on both ranges of the spectrum, we have this complication. Well, the patients who did best were those who actually received what we now consider is correct, is between 20 and 25 kilocalories per kilo body weight, and they had a reasonable number of infections. Spanish paper, a very good paper. Spaniards are very good at multicentric studies. They picked out 750 patients out of a group of 4,000, more than 4,000 patients, based on the fact that they were on pure EN or pure PN, and they defined liver complications, because overfeeding causes liver complications. And they defined cholestasis, liver necrosis, mixed pattern, very strict criterion. Very, very, very interestingly, the first 11, 12 days, you observe that the blue enteral and the green parenteral do not differ in appearance of liver alterations. They both have. Why so? Because they are septic, because they get antibiotics, because they are in shock. You know that our patients in the ICU frequently have minor or important liver test alterations. But after day 12, obviously and very significantly, the enteral group has less complications of that sort. And what happens then? Well, actually, the patients on parenteral do receive more. And there is a sort of cutoff they were able to calculate, which was above 27 kilocalories per kilo body weight per day, where liver tests were altered again. So in the ICU, there are many reasons for altered liver tests, but overfeeding is one should consider. And look what happens. And this is our computerized system, which is customized to contain 24 hours per column, because the time constant of metabolic response is much longer than what we have in the ICU. I mean, for ventilatory issues, we have a few minutes, an hour at worst. With the hemodynamic issues, we have a few hours a day to restore, but metabolic issues, they only appear down the road after 4 to 5 days. So you can't look at the normal screens the same way, and we've customized it that way. Here, the first line shows the energy target in a patient who's 50 years old, 65 kilo, dry before admission. Well, I think this is high, and our system proposes 25 kilocalories for surgical patients, which is 1,625. My colleagues prescribed 2,000. This was not a problem during the first days, because actually enteral feeding in green down here was initiated properly during the end of the first 24 hours and then progressed. The patient received 20 to 60% of the target, no overfeeding. But then 110%, 118, 120, what happened? This is a mess. The patient is overfed, and overfed to an overfeeding target. The dietitian came in and said, hey, stop. And she said, look, guys, you are providing intravenous feeds, and these results come from propofol, where the patient, which was a neuro patient, was receiving 4,000 up to 6,000 milligrams per day, which is, well, 250, 300 milligrams per hour. And then she said, please, beware, reduce the target. So there is a way to control that, and your computerized system can do it. And then, Ian, well, I've told you it's difficult to feed, and why should we then continue trying to feed enteral? Oh, well, there are non-nutritional advantages to enteral feeding. It has been repeatedly shown, and the studies, some of them are old now, but we know it maintains the plex activity with the synthesis of interleukin A, mucosal structure and integrity, limits exacerbation of inflammation, limits bacterial pullulation just by occupying the floor, limiting line sepsis because, well, the lines are not necessarily required, and reduces costs. So these are non-nutritional benefits, but they do matter to your patient. And this has been nicely shown in a very important study, which, although retrospective, was based on prospectively collected very precise data. Actually, more than 4,000 patients, and they were classified according to if enteral nutrition had been initiated within 36 hours or later. And they stratified for disease. The paper, although it's from 2006, is really worth reading. What did it show? It actually showed that if you look at 28 days mortality, or survival, depending if you're positive, those patients with early feeding got an advantage of survival, which was already showing during the first week, and which was maintained down the road. They had not fed to target, which was by the American Society's recommendation 25 to 30 at that time. They had initiated feeding, and indeed, the patients were less negative in balance, but they had their bowels working. So that is important. And then we come to this issue, what should we prescribe? Well, also a very good American study, which was wondering if we were prescribing adequately to the patient's requirements. And Stephen McClave and his team actually did measurements to their patients and looked at how they were distributed. And they compared the measurements to the Harrison-Benedict equation, which is, I remind you, a 1919 equation made by physiologists in a healthy population. And they looked at how the measurement related to this equation. And compared to that, they observed that close to 50% of the patients were so-called hypermetabolic. That means more than 10% over, more than 20% over the measurement, the calculation by Harrison-Benedict, but in an unpredictable way. 20% were hypo, and only 30% were within the estimated range. And this proportion of good estimation is something we can see in all equations. All equations fail in 70% of patients. Fail to measure the resting energy expenditure and probably the requirement, depending on the stage. We just recently, Claude Pichard and myself, we're co-workers, looked at what happened in our own population. And we took our SPN trial in which 165 patients that had repeated measurements by indirect calorimetry. And we had selected our patients on 25 kilocalories by day not being reached. And we measured. Look, for the same value here, equation says 3,300. We measure 1,990. In this patient, well, we also say the same starting point, but we find 2,300. And there are other patients where the equation in the little bird said, well, 1,250, and we measured 750. In majority of patients, we had to reduce the targets. In the vast majority, but the patients are not means. So the changes between the allocation equation and the real equation were between minus 900 to plus 700. Unpredictable. We then applied to our patients the equation which was used in Leuven. And as we had a squared R of 0.347, the squared R in the Leuven equation was even much lower. And we observed much more, actually, overfeeding. The equation which has been followed leads to overfeeding. And remember, they delivered that full already from day 2. They started on day 1, and they delivered high energy amounts very early on. While we have been taking this at day 3 and starting topping up at day 4, so we were in energy debt. What do we use? Oh, Datex. And I remind you that in an old lady, 60-year-old lady, if you measure a VO2 of 300 and VCO2 of 235, which is very reasonable, this ends up with 1,445 kilocalories. So when you prescribe 2,000 to a patient, most of our patients are there. But we can't predict. And that is the problem, and we will see in the conclusion. There are things which reduce the energy expenditure, others which increase it. And then there are technical problems. And actually, why didn't we measure it in all patients? Because actually in 30% of patients, there are technical issues which make indirect calorimetry not feasible. ECMO, these patients are just impossible to assess. We have to find something more. A reminder, all equations, I don't go into detail for sake of time, all equations fail invariably. And the main order is here. Patients change over time. VO2 changes over time as you recover. And that means that one measurement isolated in time is worth nothing. Look here, this is the follow-up of a patient we had for 100 days in the ICU, burned 72%. He was a young male. And actually we compared energy expenditure measurements in red with the equation by Toronto. And we prescribe and deliver in green very close to what we prescribe. I mean, you see in black the prescription, in green the delivery. Our nurses are good, but we adapt over time, and we're not always able to. But you observe this change over time, and the burns are, well, they are typical of these changes over time. If you have a straight equation and say this guy gets 25 or 30 kilocalories per kilo body weight, you fail most of the time. How should we do it? Well, back to panic. Actually, we shouldn't do that. And actually what they delivered by the parenteral route was probably the problem, because these patients, when you look at the total energy delivery, were just very high, and this was the equation. They actually were successful in delivering in that group their targets. And enteral feeding was poor. They say that themselves, they don't have a successful protocol. What did they find? They had a relative increase in the likelihood of being discharged alive. This is a very complex endpoint. I hadn't seen it before. But importantly, they had more infections in the early PN group. At the end of the day, p-value was 1 for death, but it was significant for infections. Early overfeeding causes infections. That is a constant. What did we do with the SPN trial in Switzerland? Well, first, we waited down the road in people who failed EN, and there was an indication to do something. We had attempted enteral nutrition. What was not the case in EPANIC. They were delivered in the group intervention, glucose 200 grams a day in the first 2 days, and then 4 p.m. And then they said that they scored for nutritional risk. Well, 3 is admission to the ICU, 1 point more is being over 70 years, and that was the repartition of their population. So 81% of their population had no indication whatsoever to parenteral feeding. What we did was to measure, and to adapt half of them, all our patients had enteral feeding, and we progressed it. We had to screen 2,550 patients to get these because we have feeding protocols which work, and most are fed enterally successfully. And then, well, for sake of time, I won't go more into this, but we had targets which were in the range of 1,890, which are a variety, and that means that we had, well, 27 kilocalories per kilo body weight. With that, we were able to deliver actually 1.1 gram per kilo body weight of proteins, which probably mattered, while the control group didn't achieve that. And we had a glucose control without any increase of insulin requirements. The two groups had identical insulin deliveries, which is also, we now know, one of the causes of that. And after the intervention, a significant reduction of infectious complications. But remember, we decreased from the equation in the majority of patients, our intakes. Our patients stayed. We had selected a population of sick patients. That is also very important. We took those where nutrition was required. And it's been shown that using the enteral route reduces mortality, but parenteral does not cause any problem if you are cautious with it. And you have seen the Gordon-Doig trial. Actually, they were targeting roughly 1,400 calories per day, which is reasonable. We are again in these cautious ways. Equipoise, non-inferiority. So, what should we do? Certainly we should go enteral when we can. Early on is beneficial, better than late, because we keep the gut working and doing other things. After day 3, if we don't succeed, it is now proven that we can do and that it is beneficial, but we have to be cautious with the targets. TPN, no problem, is the rescue in failing guts. But generally after day 3, you saw Gordon-Doig did it, and with the team, no problem. But if you're depending on total PN, you should give a total PN, which means that you should give nutritional glutamine, which will be alluded to then, and then prefer the low targets. So to conclude, early targets, beware. If you don't have a calorimeter, stay on the safe side. In the elderly, which have another body mass, I have become used to take Harrison Benedict and top it slightly up because it's really very low, but I'm counting. I'm counting every kilocalorie which is going in and looking at what I'm doing. You can make it on an Excel file. I have a fantastic system, but an Excel file can make it. And I consider covering targets when they're not achieved. And have good news. Next year, we're going to test a new calorimeter, which is going to be cheap. We have bargaining it with the industry. It will be 10,000 euro and available on the market with new technology. So do it.